That should be the presentation right there.
Perfect.
Okay. So thank you for having me. It's a real joy and no effort at all to stay up this late. So thank you for the introduction. My topic is today the microcirculation, and of course, as measured using our technology, which is the microscan. So let me just give you a little bit of background. Probably when you were in medical school or when you were studying, this is what you saw. We had these big microscopes that did the measurement of the microcirculation on the nail fold of the finger, and then we would see these tiny little loops through which the red blood cells moved, and basically that was it. And these are still in use in most major hospitals for monitoring of peripheral perfusion in diabetics and stuff like that. So when I got into research, I did it with the Department of Physiology, and then we kind of figured out that, okay, we can miniaturize the whole thing. The inspiration for that was an American company, actually, called Cytometrics, and they developed this little tool to measure the microcirculation, and they actually wanted to use it to do some other things, like measure hemoglobin. Well, that's actually technically not feasible, but we basically got the idea that, hey, maybe we can miniaturize the whole thing. So that resulted in a better way of doing it, which we called Sidestream Dark Field, and with it we can just visualize the red blood cells. We do that by using green light, which is absorbed by the hemoglobin in the red blood cells, and then you see the red blood cells moving through the capillaries and the arterioles and the postcapillary venules quite nicely. And then, of course, you need a piece of software to translate that image into a number. And we're currently at the second generation of SDF, which is now connectable to a tablet or a laptop with some sophisticated analysis algorithms behind it, so you can get a number fairly quickly in a few minutes to do the measurement at the bedside. So that is about the technology, and this is why we measure sublingually, because actually it's fairly close to the aortic arch. The sublingual artery or the lingual artery branches off fairly quickly, so it gives you quite a nice window in what is happening in the rest of the body. So for instance, if you see this was an animal study, and they made these animals septic by cecal ligation and puncture. And what you see here is very nicely that as the animal becomes septic, you will see very nicely the microcirculation of the gut follow, or the sublingual microcirculation very neatly follows the microcirculation of the gut. So they had one microscan on the gut and one microscan sublingually, and they follow each other very nicely. So what we know is that the sublingual microcirculation mirrors quite well the gut microcirculation. So it really gives you insight in, okay, what's happening in that level of the body. Now, this, of course, you probably know already, but basically we look at this compartment right here. And that looks something like this. So what you see here is you see very nicely the dots of the red blood cells moving through these blood vessels. So these are postcapillary venules right here. And here you have a nice arteriole. And then in between, you have these nice capillaries in which you see single red blood cells moving through. And what we also can see in this image very nicely is some white dots flying around. And these white dots are, of course, the leukocytes. And what is interesting, this is actually my sublingual microcirculation after an intercontinental flight. And what you see is actually more white blood cells than I would normally see in my microcirculation. So there are actually quite a few here. We've been doing some work lately to quantify that, but it's not as easy as it looks. So we're still working on that. But this is basically how a healthy microcirculation would look like. And if we then look at some examples, we try to our earlier work tried to classify the different phenomenon we were observing. This was before we had software that could rapidly give you an assessment. So we kind of divided it into completely stagnant images, or images where you had flowing capillaries next to non-flowing ones, images where you had start-stopping phenomenon, or even hyperflows where it was the blood flow was so fast that the camera just couldn't pick it up. Now, the second generation microscan has a high frame rate camera, so that hyperdynamic thing is actually less of a thing, but I will show you what it looks like. So for instance, this is pretty much what we call a stagnant image. So what you can see here is actually in the capillary. So this is actually capillary. You see single file red blood cells, and they're just completely stopped. Then, of course, in the deeper layers of the sublingual mucosa, there is some flow. But on the whole, you see these red blood cells just not doing anything, and then a few ones in the background where there is flow. But this is a very, very poor outcome image. If you would see this in a patient, then there's something really, really wrong. And we know that if this image stays like this for a few hours, yeah, this patient will most surely die unless you do something different in what you have been doing. And we'll get to that later. So this is where you see areas of non-perfusion. So, for instance, you would expect red capillaries in this area. You would expect capillaries in this area here. And actually, you can't see any. If you look very carefully, you see some single red blood cells flying around here. But on the whole, you've got flow, even flow in capillaries, next to areas where there's just not much happening at all on the capillary level. The larger vessels are preserved, but on the whole, this is a very poor image from a capillary perspective. There are very few capillaries here. And this is what you generally see in patients that are on the ICU or that are post-surgery. This is the image that you will get. So the larger vessels, the flow is preserved, doesn't look very bad, but on the capillary level, there's something off. They're disappeared, they're not perfused, and the ones that are perfused quite poorly. And what you then usually see is that there are areas where it's very poor. Right next to areas here, you see a few capillaries. They're very, very they're very big. So there is some dilation going on here. So you have areas with no capillaries and areas where you see capillaries and they're actually normally perfused. So it's also the heterogeneity of the image that really is striking for this type of patient. This is another example of what you will see regularly, is areas where there's poor perfusion next to areas where the perfusion is actually quite normal. And even on the capillary level, there is perfusion. Right? But here, for instance, you see the capillaries, there's hardly any perfusion at all. And again, in the larger vessels, the perfusion is more or less preserved. So most of the time, unless the patient is doing very, very poorly and is really going towards, the death side of things, you will see this image. So you will see flow next to non-flow phenomenon. And when you analyze the images, you will see that on the capillary level, the score is actually very poor. And this is just an example of very fast flow, or what we categorize as hyperdynamic. So you can see these red blood cells moving very, very rapidly through the capillaries. And we actually have, this is what you will see sometimes with ECMO or other extracorporeal circulation devices, where the red blood cells really are racing through the microcirculation. And we kind of had many discussions with physiologists that, okay, how fast would these red blood cells need to flow before offloading of oxygen becomes impossible. But yeah, we could not reach consensus with them, so we still don't know whether this is of physiological importance or not. But it was an interesting discussion nevertheless. You know, are these red blood cells now capable of offloading the oxygen and absorbing the CO2 properly when they're moving this fast? And this is another example, even faster. You can see that the flow is so fast that actually the camera can hardly pick it up. It's thanks to the white blood cells that we can see something moving, otherwise it would just look like nothing is happening at all. It's so fast the camera can almost not pick it up. Again, with the newer generation of SDF, this is not a problem anymore. But just to give you an idea of what it looked like. Again, this was an ECMO patient, if I'm not mistaken. So when we look at the microcirculation, of course, a capillary is defined as having a diameter of about 7 microns. But when we look at the microcirculation sublingually, we can give it a bit more space, a bit more broad definition of 10 micrometers, because we see that as white blood cells move through those capillaries, they are actually extended for a few microseconds, so that if you measure the red blood cell column behind it, it's actually a little bit more than 7 microns. And then after a few microseconds, when the white blood cell is passed, it returns to that 7 micron-ish diameter. So we kind of define it as 10 microns or less, and that is actually also what most physiologists will say is a proper definition of a capillary. Then we said small vessels, which are mostly the postcapillary venules. The medium vessels are the larger venules, and then we have the large vessels, which are, for most intents and purposes, not really relevant for any prediction or anything like that, because most of the time they're preserved. So the most data you will find in the capillary level and the small vessel level. That's where the data is. That's where you'll find your distinguishing parameters. So back in 2006, when we just launched the product, we actually used, together with very leading investigators, clinical investigators in critical care. One of them was Daniel de Bakker of Brussels University Hospital. He basically used a method used in pathology. He just drew a grid, and every place where a vessel crossed the grid, he would count it as small, medium, or large, and say, does it have flow or not? And then you will get a score, and he will use that score to calculate a perfused vessel density, which is the total number of perfused vessels divided by total, or perfused small vessel density, which is the total number of small vessels perfused divided by total of small vessels. And now with the software, we can even give you a perfused capillary density, but it's basically the same thing. But this was the time of manual analysis. 2006, it was a round table. 2007, the paper was published. And this is basically the first steps into, okay, how do we do this clinically? So now we have automatic software that does this. And if you look at literature, basically a healthy person will have a proportion of perfused small vessels, so that includes the capillaries, so anything smaller than 20 microns. So a healthy person will have a score of 95% or higher. So 95% of those small vessels have flow. Then there's an unhealthy category, which is 80% to 94% of small vessels that have perfusion. And this is a danger zone. So this is where you need to start monitoring more closely. You need to keep an eye on patients that have this. And then the real danger zone is when the proportion of perfused small vessels drops below 80%. Because several papers show that if that number is lower than 80% for about 24 hours, those patients will surely die. So that is established beyond doubt, that this number is really the lowest you can have it before things really start going wrong. And that has a very logical reason as well, because the less capillaries you have, the greater distance between one capillary to the other. So, and there is a maximum perfusion distance diffusion distance of oxygen through that tissue to the cells. So if there are less capillaries, the distance between capillaries just becomes too large for cells between them to get oxygen diffusion going on, and they will start, switching to lactate and then eventually dying off if that state is preserved for too long. So this proportional perfused vessel, you can translate in your mind as, okay, I need a minimum distance between capillaries for all these cells in between to have enough oxygen. That's the basic idea behind this number. So if you look at ECMO, for instance, there's a nice paper in 2017, and I see that one picture is off here. But what we see is that they tried weaning patients from ECMO, and when the patients, so they just dial the flow back to 50, so they have the flow, and if the microcirculation is then preserved, they can be successfully weaned off, and if the microcirculation is not preserved, then you see actually a drop in this case total vessel density, so how many vessels are visible per image, and an image is about a square millimeter. So that image should be here, but basically what you see is if you reduce it to 50%, you will see a drop in that vessel density, and then if you dial it back to 100 again, then those vessels come back again. And then you know that, okay, this patient is not ready for weaning again. Again, this was a very small study, but also a very powerful study because it shows very, very clearly the importance of the microcirculation in this whole area. And another study a year later, so this was this group actually in Rotterdam. One of the authors of that group was actually a Taiwanese person, so that person went back to Taiwan and did a bigger study with 246 patients. And what they showed actually is that the score on T is 0, so when you start your ECMO support, actually tells you something about how that patient will be doing later on. So it was very, very interesting. We don't really know what to do with this yet, but you can kind of sense that, okay, if the score is poor at the beginning of ECMO and it doesn't improve very much, then the outcome will also be very, very poor once you wean them off, if ever, which is kind of what the results showed, that the patients whose microcirculation remained poor during the whole ECMO support, they pretty much died. So that was a very, very interesting outcome. And what they suggest is actually, well, maybe we should use this microcirculation parameter as okay, maybe we should do something different while the ECMO is on to make sure that microcirculation improves or the capillaries are recruited. Most of the work in this field has been done in sepsis. So I just want to go through a few slides in sepsis so you get an idea of how it's being used at the moment. So this was the breakthrough study back in 2004. Again, this is Dr. De Bakker's group in Brussels. And what they showed is, okay, there's a marked difference in the perfused small vessel density of survivors and non-survivors. And so the PPV, the proportion of perfused vessels, improved in time for survivors. It went up, and it did not in non-survivors. So it stayed around 60%. And that was, of course, a complete new revelation to everyone in this field, saying, wow, is it really that easy? So, of course, then you see a lot of people repeating the same study. And again, this is a study done in the US, in New Jersey. the lab of Dan Steve Hollenberg, who moved to Virginia later on. Again, survivors, their microcirculation improves. Non-survivors, their microcirculation does not. And then a bigger study with 531 patients in 36 ICUs in all the world, they saw that, okay, a poor microcirculation, so PPV of even lower than 90, so that's still pretty okay, was observed in about 17% of the patients. And if that PPV did not improve, those patients had a higher risk of dying than the patients where it did improve. So then we have more and more studies proving the same points. I just won't bore you with that. I will send the slides to Joe so he can distribute it to you guys. But basically, pretty much same thing over and over again. Poor microcirculation, poor outcome. And this is the most recent one. It was just published in European Heart Journal on cardiogenic shock patients. And that was very interesting because they showed that the microcirculation was highly predictive of mortality and renal replacement therapy in patients. So if there were microvascular problems, those patients had a higher risk of renal replacement therapy and dying than the patients without it. And this is a multi-center European trial, which was part of a bigger study called the Culprit Shock, which is a huge study of hundreds of patients in about 15 European centers on cardiogenic shock. So this was a small sub-study, but very powerful results. So this is the most recent one, again showing the same results. Now, what is also interesting is that this microcirculation, the dynamics of it are actually independent of your global hemodynamics. So mean arterial pressure, lactate, O2 gap, CO2 gap, all of these things, they are pretty independent of what the microcirculation does. So we monitor all these global hemodynamic parameters because why? We want to get oxygen to the cells and we would want to get CO2 away from the cells. And we think that, okay, for instance, if the mean arterial pressure is good, then most probably the microcirculation is okay. And it turns out that it is not. So this study in 2009 shows that even though all those global hemodynamics, if they are in the green, then still you can have a poor microcirculation. And it turns out that if the microcirculation is poor at baseline, so at T is 0, it is most likely to be poor later on as well, even though you correct all these hemodynamic parameters. So that was very, very important. So in this case, it was done with mean arterial pressure. Here we have similar, but then with fluids. If you do fluid therapy and the microcirculation improves, these patients do well. If you do fluid therapy and the microcirculation does not improve, then these patients do poor. And this study also figured out that, okay, if you give the fluid therapy early, the chance of improving the microcirculation is higher than if you do it later. Well, that kind of makes sense to everyone, but yeah, now we have it in a proper study. Here we have a study where they show that if the microcirculation improves, the SOFA score also improves, which is, of course, a given. But what is interesting is that the SOFA score might not improve if you improve your global hemodynamics. So again, this microcirculation is a very, very good guideline or monitoring technology to give you an idea of what's actually happening on a cellular level. Again, same thing. If you give fluids, you improve the microcirculation and the outcome is better. This one is late versus early, and of course, early fluid resuscitation gives an earlier improvement in microcirculation and thus a better outcome. So again, same thing. So what does it all mean? Well, what it all means is that we have a cardiac output, we have a mean arterial pressure, sometimes we have a central venous pressure, but what we really need to know is what happens here in the microcirculation. So if we add that piece to the puzzle, then the puzzle is complete and we have a complete picture of what this patient is doing. And what we can learn from literature, and which is a greater body of what I just shown you, is that basically you will do the same thing. You will use fluids, you will use vasopressors, you will use inotropes. You may even use vasodilators to increase the flow in the microcirculation to recruit capillaries back to their normal function. But one, you need to start it early. Well, that's a given. You should have a goal of about 80% for these small vessels. We also know from literature that a higher central venous pressure is not always better. So it seems that there is, so that 500 plus patient study in 36 ICUs showed that patients with a CVP above 12, they generally had a poor microcirculation. And the idea is that most likely the pressure in the venous compartment is too high, thereby thereby basically pushing back the red blood cells into the capillaries. So if you lower the CVP, the pressure in the capillaries can overcome the pressure in the postcapillary venules and thereby facilitating flow, offloading of the capillaries into the postcapillary venules. So we need to be really careful with that central venous pressure, or the pressure in the venous compartment. And the fourth item is we need to make sure that if you increase the mean arterial pressure, so if you give catecholamines, better make sure that it does really improve the microcirculation. So you can do the intervention, but then immediately check the microcirculation. And if the microcirculation does not improve, you may want to not go for increases in mean arterial pressure. And actually, we've spoken to many cardiologists who say, well, you know, if the microcirculation is okay, we even accept mean arterial pressures as low as 40, wow, as long as the microcirculation is okay and we see signs of urine production. So that is a slightly different paradigm than most physicians and especially intensive care physicians would use. And the fifth part is also be careful with increasing cardiac output. Increasing cardiac output is not always good for the microcirculation. It may be good for other things like urine production, but you might not always increase your microcirculation. And then you need to figure out that, okay, if I want to increase the cardiac output, do I need to do something else that helps recruit the microcirculation, like give extra fluids or lower the CVP, or maybe even give vasodilators to make sure that the pressure in the venous compartment is not too high, or that the increase in cardiac output is not caused by a squeezing off or shutting down of capillary perfusion in favor of pressure, because that is what happens or what can happen. So these are some of the things you could consider while looking at the microcirculation and treating your patient. So that is in a high-level view of what you can do with microcirculation therapy and perfusion.
Wow.